paper presentations. I request the moderators, Dr. Ravi Shankar and Dr. Dinesh Chilla, to kindly grace the stage. Now I call upon Dr. S. Saujanya onto the stage for the paper presentation.
Good morning, I am Dr. Sushena, DNB resident from Rainbow Children's Hospital, Hyderabad. My study is on latch score. Topic is to evaluate the latch score as a predictor of weight gain and exclusive breastfeeding in newborn term babies at 6 weeks of age. Breastfeeding is the gold standard nutrition for healthy growth and development of the newborns. Breastfeeding serves as the baby's first immunization and improves the cognitive function. It is estimated that a breastfed baby is 14 times less likely to die from the diarrhea, 4 times less likely to die from the respiratory infections, and 2.5 times less likely to die from the other infections. So, breastfeeding is a natural process. Many mother and infant diets face challenges, especially during the immediate postpartum period. Incorrect breastfeeding techniques can result in insufficient feeding, which can result in excessive weight loss, hyponatremic dehydration, icterus, and rehospitalizations. With this backdrop, we conducted a study utilizing the latch score in our unit. This latch score is an objective measure to evaluate the effective breastfeeding and to identify the risk factor leading to lactation failure. This latch is an acronym for latch, audible swallowing, type of the nipple, comfort, and hold. Each component given for 0, 1, 2 with total score of 1 to 10. The higher score indicates the good latching. My aim of the objective is to evaluate the utility of the latch score as a predictor of exclusive breastfeeding and weight gain at 6 weeks of postpartum in healthy newborn term babies. Objectives were to assess the latch score at 2 assessments, first within 24 hours of delivery and second at discharge, and estimate the proportion of mothers who continued exclusive breastfeeding at week 6 and proportion of latch score, discharge and weight gain at week 6. And this study was conducted in Rainbow Children's Hospital, Hydernagar, Hyderabad on 667 mother-infant diets from October 2020 to April 2023. It is a prospective observational study. In our study, we included inborn neonates of gestational age equal or greater than 37 weeks. Excluded were outborn babies, preterm babies, term babies admitted in NICU, and mothers in conditions where the latch score could not be assessed. In this study, latch score was assessed at 2 times. First latch score within 24 hours of delivery and second latch score at discharge. The mean latch score was 7.11 assessed within first 24 hours of delivery, and after this initial latch assessment, we identified and rectified the issues related to the latch score and given psychological support to the mothers and explaining the advantages of breastfeeding to the mothers. And after that, second latch was assessed at discharge, which was statistically improving. This second slide indicates the mean latch score and mode of delivery. And in both assessment done within 24 hours of delivery and at discharge, the babies who delivered via vaginally had higher latch score compared to the babies who delivered via lower cesarean section. This is maybe due to the mothers who underwent lower cesarean section were experiencing more pain and discomfort. The first slide indicates the initial latch assessment done within 24 hours of delivery and feeding patterns at discharge. The babies who had, it is showing that the babies who had higher latch score were continuing exclusive breastfeeding and they switched from mixed feeding to exclusive breastfeeding at discharge compared to those who had less latch score. The less latch score babies were continued to giving mixed feeding and they are switched from exclusive breastfeeding to mixed feeding. This second bar indicates the second latch assessments done at discharge and feeding pattern at 6 weeks of age. In this slide also indicating the babies who had higher latch score were continued giving exclusive breastfeeding, and who were giving initially mixed feeding, they were converted to exclusive breastfeeding at week 6. Compared to the babies who had lesser latch score, they were continuing to giving mixed feeding and they are converted to exclusive breastfeeding to mixed feeding. In our unit, 66% of the babies were on exclusive breastfeeding at discharge. This was improved to 75% at week 6. Of 440 at discharge, higher proportion, almost 96%, 425, were continued to giving exclusive breastfeeding at week 6. Of 227, 76 were converted to giving exclusive breastfeeding from the mixed feeding. This indicates the babies who had higher latch score were giving exclusive breastfeeding at week 6. Utilizing ROC curve, in my study, the cutoff for latch score was greater than 8 with highest sensitivity and specificity, indicating that the babies who had latch score of greater than 8 have a higher chances of giving exclusive breastfeeding in terms of both rate and duration. The most common reason for mixed feeding at 6 weeks was inadequate secretion of the milk as told by the mother and relatives. This is my second component. The babies who had a higher latch score had higher mean weight gain than compared to the babies who had lesser latch score. In my study, we observed that the babies with higher mean latch score at discharge were exclusively breastfeeding thereafter and had a higher weight gain at week 6. The latch score is a very simple and cost-effective tool for the mothers who require breastfeeding counseling, support before discharging from the hospital and to prevent excessive weight gain. Most mothers face challenges in giving breastfeeding within the first 24 hours of postpartum, thus conducting the latch score within the 24 hours of delivery can significantly improve the feeding outcomes. In our unit, I attended the deliveries in delivery room after breast crawl, cutting the cord, routine care. Baby was given to mother for skin-to-skin contact and initiation of breastfeeding. After 1 hour, I conducted first latch score and identified and rectified the issues related to the latch score. And second latch was done at discharge, which showed statistical improvement. This study explains the early implementation of latch score in the postnatal wards will increase the breastfeeding rates and duration. Measures must be adopted to achieve the higher latch score at discharge in the form of antenatal counseling, trained lactation team, and implementation of latch score in the postnatal wards. And one of the strengths of my study is the latch score is assessed by single individual, thereby minimizing the inter-observer bias. And as of my best knowledge, my sample size of my study was larger compared to the other studies conducted in India. Thank you so much.
There were latch scores which were abnormal at the time of discharge also, which were less than your 8. So what did you do to improve their latch scores?
Actually, we have to do in the following follow-ups also, sir. But in my study, I didn't do. I just contacted the mothers at 6 weeks and I given information regarding that, sir.
So who has done the latch score?
Sir?
No, who has done the scoring? You only have done?
Yes, sir. I only done.
So you have done it 24 hours?
Within 24 hours, sir.
Within 24 hours and
yes.
Again discharge?
Yes, sir.
So have you done for all of them? I mean, you could do for so many, you have done on your own? For
yeah, sir. My own
some
only.
600 were in each group were there?
Yeah, I did, so, sir. For, in my unit, I did, sir. Actually, I am staying there only in Rainbow Hospitals, in same attached building, so I did, sir. In the evening times also, I went. In the early morning hours also, I went, sir, actually.
Very nice. So, you are a fellow or a pediatrician or what
resident,
are you?
Resident, sir, actually. DNB resident.
DNB resident. Very good. Nice. Thank you.
Thanks.
Now, for the next presentation, we have Dr. A. Navya. I request you to kindly come up on the stage for your presentation.
Good afternoon. I'm Dr. Navya from Chetnad Hospital. So this project was done under the guidance of Dr. Giridhar, and today I'm presenting my research topic, infant-driven versus physician-driven palatal feeding in preterm neonates born less than or equal to 32 weeks. So as we all know, achievement of independent oral feeding is an important pre-discharge criterion for preterm neonates. And this, in our part of the world, we do this by transitioning from tube to palatal cup feeds. So in routine practice, what we do, we wait till the baby reaches a PMA of 31 or 32 weeks or a weight of 1000 grams to even initiate palatal feed. The problem with this is it leads to longer length of hospital stay, increased burden on the parents, the nursing staff, The newer method that is coming up is the infant-driven cue-based feeding method, where we give feeds based on the cues demonstrated by the infant. So which method is better? In 2016, Cochrane has published a review article which has included 9 RCTs and has stated that responsive cue-based feeding achieved full oral feeds earlier compared to scheduled feeding, but this was a low certainty evidence. Later, many studies have been published with similar results, but these studies have either been done in high-income countries or they have included more mature neonates like 33 to 34 weeks, where whatever the method of transition, they will transition earlier. So we have devised a study where we have included preterm neonates and included the infant-driven cue-based feeding method. So in hemodynamically stable preterm infants born less than or equal to 32 weeks and who are on full tube feeds or off IV fluids, does infant-driven cue-based feeding lead to an earlier attainment of palatal feeds compared to physician-driven scheduled feeding? So this is an open-label randomized control trial done from Jan 22 to June 23, and all the necessary ethical approvals have been obtained. All infants born less than or equal to 32 weeks and on full enteral feeds have been included in the study. Infants with any anomaly precluding effective suck-swallow feeding, encephalopathic and hypotonic infants or hemodynamically unstable infants have been excluded. And parents are approached once the infant reaches 75% enteral feeds, and then informed parental consent has been obtained. And once the infant reaches 100% enteral feeds, block randomization and allocation concealment were done, and infants are randomized into either infant-driven group or physician-driven feeding group. Oromotor stimulation, KMC and NNS have been started after randomization. So this was our unit protocol, which was similar to the physician-driven feeding protocol followed routinely in all units. As I said earlier, when feeds were started when the infant reached a PMA of 32 weeks or 1000 grams, and this decision was taken by the physician along with the inputs from the nursing staff. The problem with this is there is no systematic way of transition, and it is a more pragmatic way of doing things. Now I am going to talk about a more novel IDF algorithm. So as I told, once the infant is randomized into the IDF group, daily feeding readiness assessment was done by the nursing staff once per shift, depending upon the feeding readiness assessment scale, which included the components of alertness, hunger behaviors, tone, and autonomic signs. If the infant is awake or alert, showing some hunger behaviors like rooting, sucking at the OG tube, showing good tone, and stable heart rate and respirations, it is scored as 1 or 2, and feeding is started. Then assessment during and post-feeding, 30 minutes post-feed is done on the parameters like ability to remain engaged during feeding, suck, swallow, breathe coordination, smooth, regular respirations, autonomic stability, and stress cues. If any autonomic instability or stress cues are there, feed is withheld for 24 hours and the process is repeated again in the next day. So the primary outcome that we measured was the PMA to attain full palatal feeds, and the secondary outcomes we measured were the length of hospital stay, mortality and clinical morbidities like death, BPD and feeding intolerance, growth parameters and adverse events. So to achieve a median reduction of 1 week in the PMA to attain full palatal feeds in IDF group, a sample size of 63 was required in each group. Standard statistical tests were used for analysis using SPSS. So this is the flow of participants in our study. Total 180 infants were assessed for eligibility. After exclusions, 70 were allocated in each group. After excluding deaths and transfers, total 63 were available for analysis ultimately. So this is the baseline demographics of our study. The median gestational age was 28 weeks and the median birth weight was around 1000 to 1050 grams. Other baseline characteristics were similar, like babies receiving steroids, requiring PPV, on caffeine or antibiotics. So this is the outcomes table. So the PMA at which the first palatal feed was initiated was significantly lower in the IDF group, which was 31 weeks compared to 32 weeks in the PDF group. And full palatal feed was also significantly lower in the IDF group, which was 32 weeks compared to the PDF group, which is 33 weeks. However, the time taken from initiation to full palatal feeds was higher in the IDF group, which was 8 days compared to 6 days in the PDF group. This can be attributed to the overall adverse event rate, which was higher in the IDF group compared to PDF group. However, serious adverse events causing significant hemodynamic compromise were similar in both groups. Coming to the length of hospital stay, there was a significant reduction of 1 week in the IDF group compared to PDF group, which was 33 weeks in IDF compared to 34 weeks in the PDF group. The weight gain and other anthropometric parameters were similar in both groups. We have measured the exclusive breastfeeding rates also, which was higher in the IDF group compared to PDF group. And coming to clinical morbidities, death, BPD and feed intolerance were similar in both groups. So I conclude that there was a significant reduction in PMA of initiation and reaching full Paladay cup feeds, and this faster transition resulted in reduced length of hospital stay. And transition to complete oral feeding took a longer duration, which might be due to the instability signs because we have initiated a little bit earlier in the infant-driven feeding group. Coming to the strengths, this was an RCT design, and we have included more premature infants, and we can say that Paladay cup feeds can be initiated in more preterm neonates. This is significant in LMICs, where more hospital stay equals more out-of-pocket expenditure, where financial resources are limited. And we have devised a IDF algorithm, and there was a meticulous monitoring also. Even mother was involved in the study, which is in congruence with the family-centered care that is currently on the rise. In addition to Paladay cup feeding, we have measured anthropometric parameters, adverse events, and even breastfeeding rates. The limitations were the performance bias could not be ruled out because the nurses were a little bit eager to start earlier in the IDF group. Long-term breastfeeding rates could not be analyzed, and we could analyze only at 40 weeks PMA. Economic analysis was also not done. Thank you.
Thank you very much. You have done a wonderful job. So, if you see your gestational age range, you told below 32 weeks.
Yes, sir.
So, below 32 weeks is a big one.
Yes,
so,
sir.
Because those who are below 28 weeks, they behave in a different way when compared to those who are more mature.
Yes,
have
sir.
you done that kind of a subgroup analysis?
No, sir. We haven't done any
So,
subgroup
what was your
analysis.
least gestational age?
Least was, we have included 26, sir.
So you had 26 to 28 and 2020. Okay.
Yes, sir.
Second thing, once you have done this randomization, so you have started this oromotor
Yes, sir. KMC and
stimulation,
NSN
and you have also started the non-nutritive
sucking. Yes, sir.
So whether the mothers were available at that time?
Yes, sir. Mothers were involved.
Available for all of them, or
Yes, sir. Mothers were involved in all, like through the entire study.
at the time of randomization?
Yes, sir. Actually, we have kept this protocol in places, and we have advanced the feeds according to certain milestones, sir. So once the infant is able to take 100% feed volume, at least 6 feeds per day, we have included the mother, like mother herself gives direct Paladay feeding, sir. And even to start the initiation of the cup feeding also, inputs from the mother have been taken, sir.
So it is the mother who tells that the baby is
yes, sir.
ready to feed.
Mother along with the bedside nurse, sir. Physician involvement is less.
Okay, fine, right. Thank you.
Yeah. Excellent sort of study, and I think has a lot of economics to involved in it. I think if you could send them home.
Thank you.
2 issues comes is, interestingly, the adverse events was more in physician-driven group.
No,
Though
sir.
it was-
IDF group. Infant-driven feeding group, sir.
Is it? Can I go back to that? Yeah. Could you go back to the slide? Yeah. So, what were the adverse events you were noting in this? Can you say that?
Autonomic instability signs, sir, like mild DSATs, not requiring, like apneas requiring stimulation, not that extreme, that we have classified as serious adverse events, sir. Only mild DSATs, fluctuations in the heart rate and respiratory rate, those.
So, that's fine. So, I think maybe I looked it wrong. And so, that's going to be very, did you find anything after they went home? Because you sent them 1 week earlier than expected.
Yes, sir.
So did you find anything in the follow-up in terms of the rate of weight gain, any coming back, they went up at 33 weeks, the rate of apnea coming
Yes,
back,
sir.
any other adverse events?
Actually, weight gain was similar in both the groups, sir. There was no difference in the weight
you sent them
gain.
home early, isn't it?
Yes, sir. Yes, sir.
So did you follow them up and say
Yes,
when they
sir.
came back, did they have any problems after going home?
Nothing much, sir. Even the apnea rate was also not higher in the IDF group, sir. So,
Sure, okay.
thank you.
Thank you, Dr. A. Navya. Now I call upon Dr. T. Shreya onto the stage for the paper presentation.
Good afternoon. I'm going to present a randomized control trial to evaluate the role of skin-to-skin contact in reducing the duration of phototherapy in neonatal jaundice. First, a little background. So, neonatal hyperbilirubinemia is one of the most common reasons for hospital admission. It has minor side effects like temperature fluctuations, increased frequency of stools, hypocalcemia, and rash. So, by far the most relevant disadvantage is the separation of the mother-baby dyad. So this leads to increased parental anxiety, it hampers lactation, causes lactation failure. And so because of that, in this study, we have evaluated KMC as a tool to minimize the separation of this mother-infant dyad. So how does it work? The advantages of KMC are that it allows for the continuation of treatment while encouraging the mother to participate in the management of their babies as a part of family-centered care. And it provides a positive impact on the physical growth of the infant and increases the attachment between the mother and the baby. So the premise of a study is that while giving KMC, we are increasing the milk output from the mother. This will in turn increase the lactation in the baby. So that will lead to reduced intrahepatic circulation and it increases the excretion of bilirubin. So there is a faster fall in bilirubin and it increases the rate of fall in bilirubin. Aims and objectives. The primary objective was to evaluate the efficacy of skin-to-skin contact in increasing the rate of fall in bilirubin. Secondary is duration of phototherapy, duration of hospital stay, and occurrence of rebound jaundice. It was a randomized control trial conducted in level 3 neonatal NICU. We have taken late preterm and term neonates with weight more than 2 kgs who required phototherapy according to AAP guidelines. Inclusion criteria, we've included those neonates in whom the mothers were available to provide skin-to-skin contact. And exclusion, we have excluded babies with early jaundice, prolonged jaundice, cholestatic jaundice, and any hemodynamic instability, sepsis, or congenital malformations. Methodology. So, a written informed consent was taken, and then computer-generated randomization was done, stratified for late preterm and term neonates. Allocation concealment was done using serially numbered opaque sealed envelopes. Masking of intervention was not done, but the laboratory and the statistician were masked to the group allocation. Group A, we have attempted to give 2 hours of KMC for every 8 hours of phototherapy. In Group B, we have given only phototherapy. So in Group A, the mother wore a kangaroo gown and was seated in a KMC chair in a semi-recumbent position. The baby was placed between the breasts of the mother, supported with a KMC binder, and covered only with a diaper and a head cap. In Group B, we have given phototherapy such that the maximum surface area was exposed. The device was placed as close to the baby as possible, and phototherapy was given using lullaby LED. The irradiance was checked using a flux meter, and the wavelength used was 460 to 490 nanometers. Interruption of phototherapy. So in Group A, interruptions were during KMC and breastfeeding. In Group B, the interruptions were only during breastfeeding. So these interruptions were not deducted from the total duration of phototherapy. Bilirubin estimation was done via the DIASO method, at least 12 hourly, and phototherapy stopped when the TSB was below 2 milligram per deciliter below the phototherapy threshold. Coming to the results. So 154 neonates were assessed for eligibility, out of which 88 were randomized into Group A and Group B. Out of 44 in Group A, one mother had refused KMC after randomization because she was in pain. All the others were allocated, all the others KMC was done. Intention to treat analysis was done for both the groups. The baseline variables were all comparable between the two groups except for the percentage weight loss at randomization, which was more in the control group. The other baseline variables like maternal characteristics, PIH, GDM, mode of delivery were all comparable between the two groups. Bilirubin at randomization was also similar. It was not significantly different between the two groups. The primary outcome was the rate of fall in bilirubin. So as we can see, the p-value is 0.489. There was not a significant difference between the two groups. Secondary outcomes were maximum bilirubin after enrollment, weight gain post-randomization, total duration of phototherapy and hospital stay. So all these were also comparable between the two groups. The other secondary outcomes were the feeding patterns during phototherapy and at discharge. We have classified into direct breastfeeding, exclusive breastfeeding, formula feeds, and mixed feeds. So between the two groups, there was not a significant difference. The KMC duration at the end came out to be around 6 hours for the entire duration of hospital stay, which was around 18% as compared to the phototherapy duration. This is a predefined structured questionnaire which we had given to all the mothers in group A, assessing their comfort levels during KMC. Most of the mothers were very comfortable and we had a median score of about 37. These are some of the other studies which were conducted related to this topic. So discussion, a significant difference between the two groups was not seen in our study, which might be because KMC did not affect the stool and the feeding patterns. The total duration itself was low in both the groups. The time spent in KMC was not deducted from the total duration of phototherapy. So actually, the actual duration of phototherapy is actually less in the KMC group, but that is not reflected in the results. Compared to the other studies, in our RCT, KMC was given for a longer period, and during phototherapy, the maximum duration of KMC occurred compared to the previous studies. The strengths, it is a randomized control trial with an adequate sample size. The duration of skin-to-skin contact in relation to duration of phototherapy was longest in our study. Statistician and laboratory were blinded to the groups, and LED phototherapy machines were used. It is a pragmatic study, and it is the first study which looked at the rate of fall in bilirubin feeding patterns and urination and defecation changes. Limitations, the total duration of KMC was approximately 6 hours, which was lesser than what we initially intended. Separation anxiety related stress was not evaluated. Masking of the intervention was not done, it was not possible. And phototherapy was not given, it was interrupted when the baby was put for skin-to-skin contact. Conclusions, the result of this study highlight that KMC can be given easily to all babies with moderate non-hemolytic jaundice requiring phototherapy. And giving KMC for 2 hours in each shift will not interfere with phototherapy. It is unlikely to affect the duration of phototherapy. But bonding between the mother and the baby is going to be better because most mothers in the KMC group felt satisfied by giving KMC if the babies were under phototherapy.
Yeah, it's a nice presentation. So I just want to have doubt, why did you get this idea of giving KMC to more mature babies? When we talk about jaundice in babies, we usually talk they should be given frequent feeding.
Yes, sir.
But KMC, because KMC for a more mature baby is, they do not tolerate that well. It is mostly for more premature ones and all. So why did you get this idea of KMC helping in the phototherapy? What is important is the phototherapy has to be given in the mother's room at the bedside, and we have to ensure the frequent breastfeeding. That's very important. But how did you get this idea of KMC in a term?
So most of the babies who had come for phototherapy, the main reason was there was weight loss and the mothers complained that they were not getting enough feeds. So we had a lot of mixed feeding at presentation. Most of that, in that mixed feeding also, most of the feed was formula feed. So we have a lactation nurse in the hospital, sir. So by this, if the milk output in the mother can be increased by KMC. So at the end of the phototherapy, by the time they are discharged, because the milk output is increased, the chances of rebound jaundice or this occurring again will be lesser.
So then your outcome measures have to be a continuation of exclusive breastfeeding rather than affecting the jaundice or bilirubin values and all. I mean, you just wanted to see whether the breastfeeding failure rate is more when you give intermittent with and without KMC. So you just, I think,
Yes, sir.
I have a...
So initially when they came, around 60% was exclusive breastfeeding, sir. The remaining was mixed. By the time they went to discharge, around 93.2% was the rate of exclusive breastfeeding. So I've not mentioned that, but that was it.
See, it's well proven that intermittent phototherapy and continuous phototherapy,
Yes.
You, both the group, I think, received
Yes.
intermittent phototherapy. I take it. Why didn't you, they were term babies, no? Like continue phototherapy when they were doing skin-to-skin contact. Why you sort of persisted like a KMC, like being on mother's chest, but continuing
Yes.
phototherapy?
That is one
It
of
could
our
be, if you
limitations,
could have
yes.
done that, probably the purpose of both could
Yes,
have
yes,
been
sir.
addressed, whether You know, separation anxiety would have been taken care, breastfeeding would have been done, and then whatever differences, because we know that intermittent phototherapy and there is not much difference. That's why we didn't see a bilirubin difference. But whatever our end result was in terms of trying
So
to
when
increase
the baby was put on the mother's chest, the dorsal part was covered with a binder, sir. So we couldn't, if there was a Billy blanket available, maybe in the future, maybe that can be done.
Yep.
KMC with phototherapy.
There's a way. I told,
Yes.
I gave phototherapy to my son when doing a KMC. So you can do that, but you just have to lie down. But you can give for intermittently. The 2 hour period is not that difficult. But I think we can do it. And it's a nice study, but you can design it. And what is the endpoints have to be very different. That's how probably. But well done. Thank you.
Thank you, sir.
I think all the presenters have done a good job. They are very good studies, and I appreciate the way they have gone methodically. They have done in a proper way. So that's the way, and it's a very nice presentation from all the presenters.
Yeah. Good job, all of you. Congratulations.